I'm Harry Greenspun, and it's nice to be back here. I started my career here at Hopkins many years ago. It's changed a lot. When I was here, people were, the medical students and residents were being abducted and put into the trunks of their cars and driven to ATMs. So it appears to be much improved security situation since those days. I'm a physician, started life as a cardiac anesthesiologist here, and I got involved in using technology to improve the quality of care when we were doing minimally invasive heart surgery here, early cases. And we were tracking those patients with paper forms. And at the time, the internet was kind of a new and exciting thing. And we got some grad students at MIT to build a registry of those patients. And we got that up and running in about 40 centers worldwide. And it seemed like a really better way of doing things, real-time data access, collaboration across centers, which got me interested in doing those sorts of things. So I've taken a number of different roles across my career. I was Chief Medical Officer for Northrop Grumman, doing a lot of work in military health and at the CDC. I was previously Chief Medical Officer at Perot Systems and Dell, and now I'm at Deloitte. I sit on the, I've been on the HIMSS Advisory Board. I'm on the World Economic Forum's Global Advisory Council on Digital Health. And my focus is really on how healthcare is changing, how it's transforming. And the big thing for me right now, I really believe, is the transformation of healthcare from a reimbursement standpoint of paying for the volume of work that providers and others do, to the value that they achieve, to the outcomes that they achieve. And that's going to be a real paradigm shift in healthcare, where we're going to be viewing, not valuing what individuals are doing from moment to moment for a patient, but how well they manage a population's health. And that's going to require a lot of different things. It's going to require sharing data. It's going to require coordinating care, things that we don't do very well right now. It's going to require engaging consumers in ways that we never have in the past.
What I've seen over my career is, and I've become very specialized in medical technology, and so my role is not to build the walls so much as to plan the interior of the space, to integrate major systems like imaging systems, lights and booms, surgery, equipment, movable equipment, down to the trash cans, but, thinking about how the room functions. And so I find that usually has a right and a wrong, or a better and a best kind of solution. So we look at value, we look at how does this design achieve either improved quality, improved patient satisfaction, and a lot of the trends that are happening with quality and the fear of not being reimbursed for things like hospital-acquired infection are starting to really find their way into how we're designing buildings and how we're equipping those buildings. And so it's interesting to watch the trends from 5, 10, 15 years ago, when we were concerned with how do we separate departments and maximize flexibility. Now our focus as we build buildings is can we make that care model adapt? How do we leverage technology to make these buildings more efficient? And it'll be interesting to see where we go from here. So thank you.
Thanks, Lisa. Good morning, everybody. My name is Mark Shagru. I'm a director with PricewaterhouseCoopers out of Boston, so I'll apologize once for the accent that sometimes lost in translation. I'll also thank the Orioles last night for beating the Yankees. I'm a Red Sox fan. So I'm a registered nurse by background, have spent my entire career in health IT. My nursing background is really emergency medicine, trauma. And my kids often joke with their friends that Daddy spent a little time in jail too, because I did do some corrections nursing, which provided me a unique look into some of the healthcare delivery networks. I currently, in my role at PricewaterhouseCoopers, assist clients like Johns Hopkins to identify new technologies and deploy those technologies, all with the emphasis on patient care and care delivery. I currently serve as the HIMSS Nursing Informatics Community Chair, which means I lead a group of about 4,000 nurses globally, all focused on informatics. Like Lisa, I'm board certified, but not in architecture, in nursing informatics, which means I have a focus on data, information, knowledge, and wisdom. And from where I sit, I think the industry undoubtedly, as was mentioned earlier, is going through incredible convergence. And we're seeing that convergence even with data. So I was asked to sort of prepare my thoughts for this presentation. As any good management consultant, you start with PowerPoint, right? But we're not allowed to use PowerPoint here. So I was able to boil it down all into one code, and that code is T751.XXA. And for those of you who haven't been keeping track, that's the ICD-10 code for near drowning. And I picked that because I believe that we are drowning in a sea of data in healthcare right now. We have great access to data information, the new technologies at the bedside, the great infrastructure like the building that we're seeing here, all provide us an incredible opportunity to take data and to use it. I fear, however, that we're not always doing that with the best informatics competencies in mind. Instead, sometimes our data gets lost in translation. So I'm concerned that we really need to think about how do we get better data, how do we make sure that the data that we are collecting is the right data and helps us to get the information that we need for our patients. Lastly, the glass half full perspective of this is that we have an incredible opportunity with the convergence that's going on in healthcare right now. We're seeing sort of a graying of the boundaries between historical providers and payers and even the pharmaceutical and life sciences. Genome mapping is real, it's happening. We have the opportunity to not only take electronic health record data, data from patients' personal records or social media data, but also genomic data, and to really start to make some great information and clinical decisions about patient care and care delivery. So with that.
Hi, I'm Mike McCarty. I've been here with Hopkins since 1994, and I have responsibility. I sort of have two responsibilities. One is the infrastructure across Hopkins. So everything from data centers and networks and telecommunications to we're currently building out a new high-performance computing data center on one of our other campuses for a lot of research activities. And the other responsibility is to deal with technology and trying to figure out how that technology can best be used in a hospital like Hopkins or in any kind of healthcare setting, whether here or even at home. So I became involved with this project, I guess about 9 years ago. And one of the key things I was asked to do was try and find a way that we don't have to tear the ceilings open every couple of weeks to make changes. So we did that as best we could. But more importantly, we were able to take a lot of the information we have today and information we've gathered over the years, work with our clinical staff, our nurses, the physicians, our researchers, to try and figure out what do they need tomorrow? What do they need to perform the analytics? How do we help them build the databases? How do we help them gather the information to do that? And a lot of this building was designed around the patient and gathering information about the patient, being able to review that information and make a better diagnosis in the future.
Good morning, I'm Carrie McDermott. It's a pleasure to join you today, and I am with the West Health Institute. You may not have heard of us, but we are a nonprofit with the mission of lowering the cost of health care. And the Institute is part of a broader family, also the name West Health, that consists of medical research organization in San Diego, a policy center in DC, an incubator in San Diego, and an investment fund, really designed to think about all the pieces necessary to drive lower cost. Prior to joining West, I was the Director of Healthcare at the Federal Communications Commission, so I've spent a lot of time thinking about how wireless and wired and wireless broadband can enable healthcare and do a better job of spectrum management and work a lot with the FDA on how do we deal with emerging medical devices. And I also spent some time on the payer side. I'm sorry, providers. But what I was asked to talk about today is sort of wireless as a platform for change. I think we all agree that it is. We've certainly seen that traditional models of care haven't worked. We've heard a little bit already about how delivery reform is occurring, payment reform is occurring, and we certainly know that episodic care is not the best way to manage chronic disease, which is one of our primary cost drivers. So in West Health, we talk about infrastructure independence. And by that, we mean giving patients the right care at the right time, wherever they are. And in order to do that, we're going to have to rely on wireless infrastructure. And that's both within our facility walls and outside. So as patients move from their homes via transport into the hospital, depending on which department, and then back out the other way, we have to be contemplating these systems in order that we can promote real-time remote monitoring that will hopefully give us actionable diagnostics and a seamless flow of healthcare information, because of course we're going to exist in an interoperable world going forward. But at West, our hypothesis is that we won't trust wireless outside the hospital walls unless we can demonstrate that it works. than it works within the hospital. And so when we think of those things that must function in a hospital, electricity, plumbing, HVAC, it's just taken for granted. And we believe that wireless needs to behave and perform like a utility with a known level of assurance. And so within West, we actually have a West Wireless Health Council, which is a group of about 30 hospital CTOs, CIOs, facilities, bioengineering, biomed, and clinicians who have worked on a reference architecture such that you think about wireless distribution as a base building utility. And I'll just pause there and wait for questions on that one.
Good morning, my name's Howard Reel. I'm Senior Director of Facilities Design and Construction for the Johns Hopkins Health System. I had the good fortune of being responsible for having this, constructing this building. It's a very large project, as you perhaps have seen from the outside. It's 1.6 million square feet, $1.1 billion budget, total budget. Miles and miles of copper, miles and miles of steel, tons and tons of steel, and it was a real privilege for me to be the lead for the construction of the facility. Where my involvement there was largely construction. I also feel that I was the integrator per se of all of the various design components, not only from a building standpoint, but also from an IT standpoint, clinical engineering standpoint, and other factors. Harry, when you were here previously, you probably knew that Hopkins is famous for its silos. It hasn't changed. So that really became, I feel, the most important factor so that we could bring a cohesive project together and with a success, or at least as much success as possible for all of the various parties that were looking for their wishes to be met. Another difficulty we had with this project was certainly the size, just in dollars and scope of square footage, but in time. Frankly, construction really hasn't changed a whole lot since the pyramids. It's basically resisting gravity and getting bricks and mortar up in the sky. Technology, though, changes very rapidly, and we had a 6-year construction process. And I would venture to say that we probably learned about 3 or 4 different technology changes in various areas over that time. So it's tough for construction to keep up with that. And I think going forward, that's one of the more clever things that we need to figure out is, I'm sure many of you have heard the phrase, last responsible moment. We tried that very hard here in this project, especially from the imaging side. Were we successful somewhat? Could we have done it better? Yes, absolutely. And the next $1.1 billion project I build will include that. Thank you.